Welcome to our seminar today. I'll be introducing Dr. Rebecca Hubbard, who is a professor and vice chair for faculty professional development in the Department of Biostatistics, Epidemiology, and Informatics at the University of Pennsylvania. Her research utilizes statistical methods to address the messiness and complexity of real-world data. Specifically, Dr. Hubbard's research addresses challenges that arise from using electronic health records and claims data in research, such as informative observation patterns, missing data, and measurement error. And our work focuses on the development and application of methods that can improve our abilities as researchers to utilize these types of data. So our methods have been applied to support the advancement of a broad range of research areas, including health services research, cancer epidemiology, aging and dementia, and cardiology. Dr. Hubbard is also an elected fellow of the American Statistical Association, a statistical editor for the New England Journal of Medicine, and has published over 200 peer-reviewed papers. So it is an absolute honor to have her here today to present her work on opportunities and challenges for advancing health equity through electronic health records-based research. So please join me in giving a warm welcome to Dr. Rebecca Hubbard.
Thank you so much, Brooke, for that really kind introduction. And thank you to all of you for taking your lunch hour to come hear about statistics, which I always appreciate. I don't want to move too far from the computer because I think I'm being recorded, so I will try not to drift. But as Brooke said in her introduction, and as I think you can see from my slides, I'm a biostatistician, and so that's the lens that I bring to this research. But I really see it as a multidisciplinary endeavor. And it's one of the things that I love about working on research using electronic health records is we have to bring together people from a lot of different perspectives, the quantitative perspective, as well as the clinical perspective, as well as the population health perspective, epidemiology, et cetera. And so much of my research is really grounded in taking that multidisciplinary perspective and trying to use it to understand the data. Where did they come from? Why do we have the data that we have? And what does that mean for the methods that we should be using and the kinds of conclusions we can draw? So I'm going to talk a bit about those concepts, go a little bit into some specific statistical methods, but I think not too much. I think there's only one equation, not too much statistical detail, but I'm happy to answer any questions if there's anything that's either that it's too high level and you want me to go into the details, or the opposite. If you're like, that's confusing, I don't know what that jargon means, please feel free to ask. So I've been working for many years on the topic of using data that were created in the process of routine clinical care for research purposes. Often that's electronic health records, sometimes it's also medical claims data. This is something I got interested in a number of years ago when I was working for Kaiser Permanente, Washington. I was in a research institute that was embedded inside of that healthcare system. And so we had access to data from the healthcare system. People wanted to use it for research. I saw it in a very granular, on the ground kind of way. And I saw that it was very messy, incomplete, had a lot of errors and challenges. And so as over time, people have become more and more interested in using that kind of data for research, I've been very interested in making sure that the ways that we're using it are actually valid and lead to valid conclusions. So this concept of using electronic health records for research and dealing with data quality issues and messiness of data was not a very sexy topic until a particular seminal event in human history happened, which is the COVID-19 pandemic. So the COVID-19 pandemic, as this perspective piece said, really prompted huge growth in use of healthcare-derived data for research purposes. It was an unusual situation in that there was a specific, really timely need for evidence about the effectiveness of different treatments and vaccine effectiveness. And traditionally, people would have conducted clinical trials to answer those kinds of medical questions. But because of the urgency and the need for timely evidence, people started to say, well, we have all this data that's being collected in routine clinical care. You know, people with COVID are going to the hospital, they're receiving different treatments. Why don't we just use that data to learn about what works and what doesn't work? So there was a big uptick in the interest in using these routine collected data for research purposes. And then, like most things, most human endeavors, there was a lot of enthusiasm, and then there was a lot of backlash. So people said, hey, let's use these data instead of conducting trials, which I think is a pretty misguided perspective. And then there was a backlash against that that said, wait, no, you cannot replace clinical trials with this kind of observational research. This perspective piece was in New England Journal of Medicine. It upset a lot of people who do the kind of research that I do. They really didn't like the idea that suddenly so-called real-world evidence or evidence derived from electronic health records was being called a myth. So what I think is the perspective that we really need to take, and that I'm going to sort of advocate for in my talk today, is the one that's represented in this perspective piece, which basically called for balance. It said, realistically, there's no magic to clinical trials. There's no magic to randomization, but similarly, real-world evidence is not a myth. There are good things about each of these different kinds of research. There are strengths and weaknesses. So that's the perspective that I try to bring to this research. Let's be realistic about what we can do with routinely collected data. They can allow us to answer questions that have been difficult or impossible to answer using primary data collection. On the other hand, they have substantial limitations that we need to acknowledge and account for. So in my talk today, I'm going to specifically focus on thinking about ways we can move beyond what we can do with clinical trials using EHR data and try to do it in a way that preserves research rigor. So let's not fall into the trap of just assuming these data are like any other data. We can just plug them into a statistical algorithm and get an answer. We need to think carefully about where they came from, but I think they can really allow us to move beyond the questions that we could answer using clinical trials. Much of my research is in the context of oncology. So throughout my talk today, I'm going to be referring back to an oncology example that I'm going to introduce in a minute. But as an example context, oncology is a field in which clinical trials are really considered to be the gold standard. So a clinical trial is sort of given a pass. People assume by default, if you randomize participants, that must represent a higher standard of evidence than if you conducted an observational study and no randomization was involved. And of course, that's an unrealistic perspective. You can conduct a pretty garbage clinical trial, and you can also conduct a very high quality observational study. But historically, people have really considered clinical trials to be the gold standard for estimating efficacy of treatments. However, there are significant limitations to clinical trials, even a well-conducted clinical trial. And one of those limitations is that they often have limited external validity. So the patients who participate in clinical trials don't necessarily look like the patients receiving treatment in routine care. The way that care is provided, the clinicians who tend to participate in clinical trials don't necessarily deliver care the same way as the general population do. So if we use data that are routinely collected in the process of patients in the real world receiving treatment in community cancer centers, for instance, that gives us a window into what treatment and outcomes look like in a patient population and a clinical setting, which is fundamentally different from the context of a clinical trial. Oncology trials are also problematic in that they systematically underrepresent certain populations. So NCI has been trying for decades to increase representation of diverse racial and ethnic groups in phase 3 oncology clinical trials. But progress is really slow, and they're still substantially underrepresented. Additionally, the example I'm going to give today focuses on patients who are poor prognosis. So patients who are sick and frail also tend to be underrepresented in clinical trials. However, those sicker, frailer patients are specifically the ones who, once the treatments are approved, are going to receive those new treatments. So looking at data from the EHR gives us a unique opportunity to evaluate how these treatments perform in those populations. So when I think about conducting research using EHR, there are two primary sources of bias that I'm concerned about. One source of bias is information bias. Information bias arises from the messiness, all of the problems with the data that arise due to the fact that these data were not collected for research purposes. So for instance, measurement error is very common, misclassification is common. Often we're relying on things like diagnosis codes. Those diagnosis codes don't necessarily correspond well to the conditions that we're actually trying to capture. If we had designed a research study, designed assessment of the conditions that we're interested in, we probably would have done it in a more precise way, using better standardized labels, better standardized measurement and assessment than what's represented in diagnosis codes, procedure codes, et cetera, in the EHR. Additionally, because of the heterogeneity and the inconsistent capture of information in the EHR, we're going to have a lot of missing data. So the specific data that are available for a given person are going to differ across our patient population. So for all of these reasons, when we look at the data that we have available for analysis, it's going to be frequently missing, often error prone. And if we don't account for that missingness and that error in our analyses, it's going to propagate into the form of bias in our downstream results. At the same time, if we're interested in a task like comparing two treatments, confounding is a major issue. So obviously, patients who receive one treatment in clinical care are receiving that treatment for a particular reason, and therefore don't necessarily look like other patients treated with other agents. The information that we have available in electronic health records to try to capture those differences in the patients receiving different treatments are somewhat limited. So things like behavioral risk factors and social determinants of health are rather poorly captured in EHR data. There's a lot of interest, especially with the growth of large language models, in mining narrative text notes. So the physician's notes, nurses' notes, things like radiology reports, to try to derive some of these additional, more detailed pieces of information. But the thing that really worries me about that, and the thing that I often talk with statisticians who are thinking about using these data about, is that that information is not consistently captured across individuals. So if you have an individual who has a doctor's note that's been written down that says this person practices yoga 5 times a week, yes, that tells us that they practice yoga, but if we were to mine the notes and extract that information, the people who have that information available obviously had a very different encounter with our clinician than the average patient. So the availability of that information, because it's non-standard, is likely related to other characteristics of the patient. Additionally, things like family history and disease severity potentially could be captured in EHR. So there are fields that could record that. There are codes that could represent that. But again, because they aren't required, they are not typically consistently collected. So missing this in those pieces of data tends to be informative. It's related to other characteristics of the patient. So in general, because EHR data were not collected for research purposes, they generally are not research quality. And we need to be aware of that when we go to analyze them and take steps to make sure that we've accounted for the ways in which they're deficient relative to standard primary data collection research sources. One of the aspects of EHR data quality that I find to be the most fascinating is the issue of data provenance. So data provenance describes the process by which data come to be available in the EHR. On the right-hand side of this slide, I have a course diagram summarizing at a high level how I think about this happening. So basically, when we analyze these data, what we see is the EHR data down here. So we have administrative data that's sort of necessary for provision of care and billing and reimbursement. Then we have structured data, things like procedure codes and diagnosis codes, and we have unstructured data in the form of narrative text notes. That's what we see. But that data that we see has resulted from this funneling process that results because the patient chose to come into our healthcare system. And so there's a selection bias piece right up front, who presented for care. Then there's the nature of the interaction between the patient and provider. So if we're interested in a particular piece of information, like whether or not someone practices yoga, the interaction between the patient and the clinician has to have actually touched on that piece of information. And if it didn't, then it's going to be invisible to us. even if it did, it has to actually be documented. So if you think about, you go to see the doctor and the nature of the conversation you have, you may discuss all sorts of things, but what they choose to put into their note or click the radio buttons for is a relatively small subset of that information. So we're going to lose information that's not documented. And then additionally, there's all sorts of extra and erroneous information that ends up in the EHR due to idiosyncrasies of how medical records coding works, how billing and reimbursement works, and things that are just frank errors. So as a result, we end up with this rather distorted snapshot of what the patient's health looks like. And additionally, the amount of information we have, its depth, the type of variables that are recorded are going to vary across patients depending on their access to the healthcare system, the nature of the interaction they have with their provider, and so on. So to the extent that clinical practices vary depending on the patient that's in front of a given clinician, the quality of information available in the EHR is going to look different. I think most worryingly, this means that patients from historically medically underserved groups are going to have poorer data available. And so if we aren't thoughtful about these issues, I think we risk perpetuating bias by assuming that what we see in the EHR represents the truth about a patient rather than a distorted snapshot. So I'm going to give you two examples of studies that I've conducted with electronic health records this afternoon. The first one is a substantive study investigating a question about a new oncology treatment in routine practice. And then the second one is a methodological study that we conducted in response to a question that came up in the course of conducting our substantive study. So the first of those two studies that I'm going to talk about investigated use of immune checkpoint inhibitors, which I'm going to refer to as ICIs and also as immunotherapy, for treating advanced solid tumors. So ICIs or immunotherapy have rapidly diffused into routine clinical care in oncology. They're very popular treatment because they're less toxic than chemotherapy. So in general, they have less severe side effects. So once ICIs were approved, they rapidly started to be used across the patient population with advanced solid tumors. But the trials that had led to the approval of those treatments completely excluded frailer patients. So even though the frailer patients weren't included in the trials, they're eligible to receive the treatments in routine practice. And because the treatments have a less toxic side effect profile, they're actually very appealing as a potential alternative for frailer patients. So the oncologists that I was working with were interested in answering this question about whether or to what extent ICIs were being used in the frailer patient population in whom we actually had no evidence from trials of the effectiveness of these treatments. And then additionally, they were interested in the comparative effectiveness question. If we compare ICIs head-to-head with chemotherapy in real-world practice, how do they perform in this sicker, frailer patient population? So with a number of my colleagues from oncology at Penn Medicine, we conducted this study that was published, I think a couple years ago in JAMA Oncology, answering this question about immune checkpoint inhibitor uptake and comparative effectiveness relative to chemotherapy in patients who were excluded from clinical trials due to their frail medical status. To answer this question, we used data from a large oncology EHR derived network called the Flatiron Health Network. So this map is illustrating the sites that contribute to Flatiron Health. At this time, I believe the network has expanded from 265 to about 280 cancer clinics across the US. They're primarily community cancer clinics, so mostly not academic medical centers like Penn, although Penn is one of the sites. But for the most part, these are community cancer centers. So the people who we have in this database look like average patients in the real world being treated by average clinicians from real world cancer clinics. A really important point I think that this makes is while there are over 200 clinics participating in this network, and there are over 2 million patients whose data are captured, when we go to study any particular cancer or any particular indication for a treatment, the patient population available is actually relatively small. So we'll see when we drill down to the patient population that we're interested in for this study, we're talking about a few thousand patients. And I often work on studies where we're interested in a particular indication for whom there are only a few hundred patients. So I've often encountered a bias that where people assume that EHR data or these modern data sources must represent tens of millions or hundreds of millions of patients. They call this big data. And they think, well, we don't even need to worry about bias because this captures the universe of everyone who has this condition. And in fact, that's very much not the case. It still represents a sample from the population that we're interested in. And often the sample is relatively small once we apply all of the relevant inclusion-exclusion criteria. So the study that we conducted to answer this question about immunotherapy uptake and effectiveness in real-world populations used a pretty standard retrospective cohort study design. We included patients with 4 different advanced solid tumors, and then we divided them into 2 groups. So based on their functional status, we divided them into those who were considered trial ineligible, so patients who would have been too sick to qualify for the clinical trials, and then patients who we considered trial eligible. We then conducted 2 studies nested in this cohort. The first is a utilization study. So we looked at who is receiving these treatments. They weren't actually proven to be effective in the trial ineligible population. So to what extent are those trial ineligible patients being exposed to these therapies? And then we conducted a second study among the trial ineligible patients in which we looked at the effectiveness of immunotherapy relative to chemotherapy. So as EHR-based studies go, I would say this is a fairly standard comparative effectiveness question and study design. And there are a lot of statistical challenges that arise in trying to answer this kind of question. So first, as I said earlier, missing data is ubiquitous. It's everywhere. Probably the one variable that we didn't worry about missing this in was treatment. We assumed that it was accurately captured in the data what treatment someone received. But almost everything else, even including survival, is potentially missing. So there's lots of missingness. We know there's confounding by indication. The patients receiving immunotherapy don't necessarily look like the patients receiving chemotherapy, and there's missing data in the confounder variables. I'm going to focus in particular on missingness in a variable called ECOG performance status. So in oncology, ECOG performance status is a very important confounder variable that describes the overall functional status of a patient. So status 0 means you function fine, you aren't limited in your daily activities, and then higher numbers represent greater functional impairment. So ECOG performance status was very important to account for in terms of looking at whether sicker patients were receiving immunotherapy relative to chemotherapy. However, it is very frequently missing in the data set. In addition to those challenges related to missingness, we also had to deal with a statistical challenge related to non-proportional hazards. Sorry, we had to deal with a challenge related to non-proportional hazards. If you're using Cox proportional hazards model, it makes us use of an assumption of proportionality, which is often violated in studies of immunotherapy in particular. So at a high level, the approaches that we took were firstly to account for missing data using multiple imputation. Then once we had imputed those missing confounder variables, we used propensity score inverse probability weighting to deal with confounding. And I'm also going to show you an E-value, which quantifies robustness of results to confounding. Because of the fact that we're using both multiple imputation and IPW, our IPW needed to be nested inside of the multiple imputation. So that adds to the computational challenge of this analysis. The specific approach to multiple imputation that we used is called multiple imputation via chained equations. Multiple imputation via chained equations is a very popular approach in EHR-based studies because it's flexible. It allows you to account for missingness in many different data types. So it can deal with continuous variables, categorical variables, et cetera. And this is essentially an iterative approach in which you specify a model for each variable that has missingness. You impute that variable, and then you use those imputed values to impute other missing variables. It's very frequently used, and often people use it almost by default without thinking really carefully about those models that are specified for each of the variables that they're trying to impute. So when I talk with people about mice, I will sometimes emphasize this point that the process of specifying a model for each of the variables that has missingness in your data set can really be quite laborious. And the response that I've have frequently heard is, well, no, it's not hard. You just use every variable to impute every other variable. And while that's definitely the default, it becomes much more complicated if you think carefully about derived variables, interactions, and nonlinear relationships. So what we need is for our imputation model to reflect all of the complexity and richness that's going to be reflected in our downstream model for the outcome of interest. So if that model is going to include interactions or nonlinear terms or derived variables, we need that to be reflected in our imputation model as well. And doing that upstream before we've actually undertaken the imputation can be quite challenging, and really thinking it through carefully takes a lot of time. Often, however, people don't think it through carefully and just dump in all of those main effects and say, well, I'm just going to use every variable to predict every variable. Additionally, parametric models may just not be very good at predicting the variables that are missing. So the imputation models may provide a poor fit in complex data sources. And then finally, and this is really the methodological challenge that I'm going to talk about later in my talk, it's computationally intensive for large EHR samples. And especially when you're doing something like inverse probability of treatment weighting nested inside of the imputation, it can become quite time consuming. So if we could think of ways to do this more computationally efficiently, which is what I'll talk about coming up, that would definitely be preferable. So the primary approach that we use to deal with confounding is inverse probability of treatment weighting via the propensity score. I am not a big causal inference person, so I tend to think about propensity scores from a very pragmatic perspective, which is that the propensity score here represented by E is a unidimensional quantity that I'm using to summarize all of the information that tells me about how patients receiving one treatment are different from patients receiving another treatment. So I really think of it as a dimension reduction tool. We're taking all of this information in the confounders X, and we're collapsing it down into this one variable, E. So if we want to estimate this quantity E of X to summarize how patients receiving one treatment are different from patients receiving another treatment, we can do that lots of different ways. We can use any supervised learning approach that we might happen to choose. And once we've got that estimated propensity score, we can incorporate it into our analysis in a variety of different ways. In the example I'm going to show you, it's via inverse probability of treatment weighting. But many people prefer matching or stratification. The other approach to confounding that I'm going to show you results for, which I think is worth considering, is sensitivity analyses to assess robustness of your results to unobserved confounders. So even though we've captured all of that information about patient confounders in our propensity score E, it's likely that there are additional variables that weren't collected, that aren't available to us in the EHR, that do represent real differences between patients receiving each of the two treatments. So the E value is a way to quantify the robustness of our results in one number. And it basically tells us about the strength of association that would be necessary between an unobserved confounder and both the exposure and the outcome in order to have changed our results. So the bigger the E value is, the more robust our results are. If we see an E value of something like 10, that means there'd have to be an incredibly strong confounder to change our results. If we see an E value like 1.1, 1.2, it means even a small amount of unobserved confounding would potentially have changed our results. So there are people who are big fans of the E value. There are people who are big critics of the e-value. Happy to talk about pros and cons of this as an approach. But as a sensitivity analysis, I like it because it's super easy to compute. We can do this with a calculator. We don't even need statistical software. So there's really no excuse not to do it. And while it's certainly not precise, it gives us a ballpark sense of how sensitive our results might be to unobserved confounding. So to show you the results, these are the utilization results for 2 of our cancers. In the blue or black line, I'm showing you the utilization of immunotherapy in the trial ineligible population, and the yellow line is showing utilization in the trial eligible population. So you can see after these treatments came on the market, there was a pretty rapid uptick in their use. And that uptake in use was more rapid in the trial ineligible population than the trial eligible population. So the patients for whom we actually have no evidence that these treatments are effective were the most likely to receive them. We see the same uptick in use for these 2 cancers, although less strong, and also there's less separation here between the 2 populations. But we definitely conclude that the trial ineligible population are receiving these treatments at least as frequently as the trial eligible population. These are the results of our second sub-study in which we looked at the comparative effectiveness of immunotherapy compared to chemotherapy. So here I'm showing survival curves for 3 different treatments. ICI combination therapy, which is receiving both immunotherapy and chemotherapy, ICI monotherapy, which is immunotherapy alone, and non-ICI treatment, which means chemotherapy alone. These curves are unadjusted. So this is just a crude assessment of how overall survival looks in patients receiving these different treatments. But definitely at this crude level, I would say, well, there's no strong evidence that there's any benefit to receiving one of these treatments versus another. And when we drill down into the numerical results, we see essentially the same thing. So because of the non-proportional hazards, we have to look at the effectiveness in early versus late periods separately. And if we look at the early period, it looks like maybe early in follow-up, ICI monotherapy was actually a little bit harmful relative to chemotherapy. Later in follow-up, maybe there's a small benefit. But when you translate that benefit from a hazard ratio into a restricted mean survival time, so an actual survival benefit in these patients, we're talking about something on the order of a month or less. So overall conclusion was these treatments are being frequently used in the trial ineligible patients, but there's very minimal benefit, if any. However, in the process of conducting that analysis, lots of challenges from a statistical perspective came up. And although we used the approaches that I described, we felt that some of them were definitely suboptimal, and we wanted to investigate alternative approaches. So one of the things that I think is quite interesting is to think about whether or not the missing data problem in EHR can actually be considered a measurement error problem. So in EHR research, there are many confounders that we don't have data on, things like severity of disease. However, there's lots of other information in the EHR. So maybe we don't have information on something like performance status, but we have lots of information on diagnosis codes for other comorbidities, hospitalizations, things that give us a window into the health of the patient. So rather than thinking of this as a missing data problem, in which we say, hey, we're missing performance status, we're going to impute it from the other data elements, we could think of it as a measurement error problem. We're not going to look at the gold standard variable, which is performance status. Instead, we'll look at a comorbidity score, which we could consider an imperfect proxy for performance status. So because we have so many different variables available, we could think about relying on other, possibly more frequently collected, but less accurate assessments of the quantities we're interested in. In particular, since we're doing this inverse probability of treatment weighting using the propensity score, we could think about the propensity score itself as representing either either missing or mismeasured variable. So in this example data, let's say we're interested in estimating our propensity score based on these patient characteristics. Some of them are poorly measured in EHR data, like smoking. So for anything that's missing, we end up with a propensity score that's missing for that individual. We could think about that as a missing data problem, or we could think about constructing a propensity score using only variables that are completely assessed across all patients. So rather than using the complete set X, if we use a reduced set of variables X star, we can construct a propensity score that doesn't have any missingness, but that doesn't necessarily reflect all of the richness and the complete confounder control that we would like to be doing using the variable E of X. So if we think about this as a measurement error problem, we could consider estimating both E of X, our gold standard propensity score, and E of X star, our mismeasured propensity score, and then try to calibrate that E of X star based on the relationship between E of X and E of X star in the patients who do have complete data. So we'll estimate both of these propensity scores, both the gold standard and the error-prone proxy. We'll then fit what's called a calibration model, where we regress the gold standard propensity score on its mismeasured analog. And then we'll generate just a single imputation of that gold standard propensity score using our calibration model. So this is an approach called propensity score calibration that's been advocated in the EHR literature, although not used very much and never compared head-to-head against missing data approaches. So we're going to do that using data from the Flatiron Health data set to conduct what's called a plasmode simulation. So in a plasmode simulation, we would like to conduct a simulation study in which we know the true relationship between a variable of interest and the outcome. In this case, we'll think of our variable of interest as immunotherapy and our outcome of interest as overall survival. We want to do this in a simulation context so we know that true relationship and we can compare the performance of alternative methods against that truth. However, we also want our simulation study to reflect the richness and complexity of the real data. So we don't just want to simulate from a standard parametric distribution, like we drew some variables from a normal and some variables from a binomial distribution. We really want to capture the correlation among all of the variables and the potentially non-standard distributions. So in order to do that, we're going to use an approach called plasmode simulation, in which we take all of the covariate data and we draw a bootstrap sample from that covariate data. So our simulated data are just a sample from the real data. They still reflect all of the relationships observed in that data. We're then going to simulate outcome data according to some assumed known relationship between those covariates and the outcome. So we preserve that aspect of simulation studies of knowing the true parameter value. Once we've done that, we'll then go through and introduce missingness according to some mechanism of interest. So if we are particularly interested in complex missingness patterns, perhaps in which characteristics of the patient that aren't recorded in the EHR reflect what data are available, we can introduce that kind of missingness. So I'm going to show you results for 3 different missingness mechanisms that all of which I think potentially could be at play in missingness in ECOG performance status in this kind of example. So firstly, under missing completely at random missingness, we assume that missingness in performance status is completely unrelated to anything else. It's just like a data entry error. They didn't bother to write it down, but there's no particular variable that explains the missingness. We're then going to look at a missing at random missingness mechanism in which we assume that there are other variables in the data that are predictive of missingness in ECOG performance status, but ECOG performance status itself doesn't determine whether or not the value is recorded. And then finally, we'll look at a missing not at random missingness mechanism in which we allow both other variables and performance status itself to influence the collection of performance status. So missing not at random missingness is always, it's kind of the statistician's nightmare. It's the most pernicious situation where the missing data is due to some cause which you cannot observe. So there's really no way to account for that missingness, and most of these standard missing data approaches fail. So we're going to conduct a plasmode simulation nested in this context of Flatiron Health. We're going to focus on one specific cancer, in this case, just metastatic urothelial cancer. We simulated the data according to the approach that I described, introduced missingness, and then we're going to investigate the relative performance of either just dropping missing observations and conducting a complete case analysis, using mice to do multiple imputation, or using propensity score calibration to treat this instead as a measurement error problem. In the paper that reports these results, we show bias, standard errors, confidence interval coverage, probabilities, but in the interest of time, I'm only going to show you results for bias. These are the bias results across the set of scenarios that we looked at for the 3 different methods. So the 3 panels represent the 3 methods that we've applied to the data. We're looking at the 3 different missingness mechanisms, and then within each of the missingness mechanisms, we're looking at different proportions of missingness in ECOG performance status, ranging from 10% to 70%. So we're looking at some very high missingness scenarios here. The first thing that you can see is that complete case analysis is biased. So as soon as we move away from missing completely at random missingness, complete case is going to show bias in our parameter estimate for the hazard ratio, and the magnitude of that bias increases as the proportion missing increases. So that's not surprising. We're throwing out information additionally, so we lose efficiency. Both the multiple imputation and propensity score calibration approaches perform really similarly. They both were able to account for most, but not all of the bias in this setting. And the thing that I think is really notable here, but is essentially a special case, so I would not rely on this in future studies, that they also worked quite well under missing not at random missingness. So I was not expecting that. And I generally would not trust anyone who says they have a method that fixes their analysis under missing not at random missingness. But I think in this case, we had some variables that were so highly correlated with performance status that it essentially became almost a missing at random situation. So in general, multiple imputation and propensity score calibration look really, really similar here. The one way in which they're very different is when we took a look at computational efficiency. So we looked at runtime. We look at runtime, you can see complete case analysis is really, really fast. There's no iteration involved there. The more missingness you have, the smaller your data set is, it gets really fast. Propensity score calibration is many times faster than multiple imputation, so more than an order of magnitude faster than multiple imputation. In this case, our data set only had a few thousand people in it, so we could afford to sit there and wait for the multiple imputation to run. It was not a big deal. If we had a larger data set, like a commercial claims database, for instance, where it's infeasible to run 30 imputations with inverse probability weighting nested inside, propensity score calibration appears to be a very viable alternative. So a couple things that I just want to summarize from this methodological investigation. Firstly, that although propensity score calibration is used far less often in EHR-based studies than multiple imputation, we found that it performed very well in terms of controlling bias while substantially reducing computation time. However, an important thing to keep in mind about this approach is that we're calibrating a mismeasured propensity score, which is only estimated using whichever variables are completely available across everyone. So if the missingness in our confounders tends to be confined to just a few variables, it works pretty well. As that missingness starts to get dispersed across many variables in the data set, the number of variables that we can include in that mismeasured propensity score gets smaller and smaller, and the performance of this approach is going to start to degrade. So trying to choose which approach you would use really depends on a number of different aspects. It depends on the sample size. It depends on the computation resources that you have available. It depends on the missing data pattern that you expect to see in your data. So just to summarize some of the things that I learned from this series of studies, when I think about the reasons that we might rely on secondary data sources like EHR to conduct research, what I would say is probably their biggest strength is that they reflect what's happening in a real world population. So we aren't limited by the clinical trial population or the population that's willing to participate in research. We're actually able to see what goes on in the real world. So that immediately expands the type of questions that we can answer and the types of populations that we can answer those questions about. However, I don't want to overstate that point because it's also important to think about that there are barriers to access, and the patients who turn up in the EHR data sets are not necessarily the same as the total population of patients affected by a given condition. So thinking about selection bias in who even makes it in the door to get into our data set, to get into our analysis, is also really important. I'm very interested in comparing trial populations to populations who are underrepresented in those trials. And I think there are lots of ways that we can expand that research moving forward to try to learn more about patients and populations that have been historically underrepresented and excluded from research. However, anytime we try to use a data source that was not collected for research purposes to conduct research, there are going to be methodological challenges that we need to think about. There are the information bias problems that I talked about early on in my talk: missing data, measurement error, confounding, error and confounder, selection bias, informative observation, et cetera. I tried to illustrate in the first part of my talk, the substantive part, that there are suites of methods. There are whole journals filled with new statistical methods for addressing these kinds of problems. So it's not like these are completely novel, never before considered problems. There are lots of ideas out there. But I think it can be quite challenging to bridge them, to put them all together to address multiple challenges simultaneously. So we're not going to have the luxury of saying, well, in this data set, I'm worried about selection bias, and I'm just going to worry about that and forget about the measurement error and all these other problems. In real world practice, there are many practical issues that are going to come up, and we need to figure out how to bring these methods together to address all of them simultaneously. Another interesting direction that I think about, which I think is becoming quite popular in the EHR research domain, is bringing together EHR data and other data sources. So bringing together EHR data and trial data, EHR data and cohort study data, and so on. There are some fundamentally unsolvable problems with EHR because of data quality limitations, and those can be addressed by combining them with other data sources. But when we do that, we have to think really carefully about differential data quality between those two sources and make sure that we're doing it in a way that's smart. So as I said at the very outset, I like this because it's such a multidisciplinary area. We have to bring lots of different kinds of people to the table, understand lots of different perspectives. I think statistics contributes a lot in this area, but understanding what many different disciplines can contribute is really important. And I think we can make a lot of progress. Thank you. Question?
We do have, we usually start with students. There are students who have questions. Really uncomfortable.
So, thank you for the presentation. It's great. I was wondering what you said at the beginning. Is there any tool or piece of evidence, thinking, for example, of cancer, that would suggest in clinical trials the responses vary by ethnicity, or is it, I'm just wondering, well, because I can imagine that in some cases it would be important, and maybe in some others, we might, people, it's not really the data we have to get, but I will know better.
That's a really interesting question. A lot of the work that I've been doing recently has been looking at racial and ethnic disparities in different aspects of cancer care, both utilization and outcomes. And usually when we're talking about medical treatments like chemotherapy, we sort of start from a default assumption of this should perform the same in everyone. This should be equally effective in everyone. And I think that's true in terms of the drug itself, but because people don't just receive the drug in a vacuum, they receive it inside of a care context. I think there are reasons that you really do and can and do see differences by ethnicity. I was just reading a study a short time ago that was looking at a cancer treatment, and it was an international trial, and they separated their study population into China and rest of the world. And there was actually a really good reason for doing this, which had nothing to do with biology, but just had to do with the care context in China, the way that this particular patient population was treated and what standard of care was there is different from the rest of the world. So, you know, that sort of contextual variable could affect treatment outcomes. And then additionally, you know, in the US, we see all sorts of disparities in the types of care that people are offered, the way that they're treated, the environment that they're in once they leave the doctor's office and go home. And all of those things could contribute to differences in effectiveness. So we do usually, our default assumption is this should look the same for everybody, but it doesn't always. And when it doesn't, I think there are lots of reasons for that. Yes.
This was great. I also do some work in health records and race, and I think race is such an interesting variable in health record data because it is like often missing, not at random, sometimes maybe misclassified the way an individual would self-identify. Do you have thoughts on sort of these tools for working with race data if you're trying to not just drop everyone who's listed as unknown or figure out how to kind of work around that?
That also is a really good question that I can tell you, I have some thoughts about it, but I wouldn't say that I have a good answer to that. So I think historically, you know, up to the present moment, the way that people have used race data in medical research is extremely naive. And usually if we have something recorded for race, we just take that, you know, we say, okay, and increasingly, you know, people are trying to make sure that that variable is at least self-reported. But honestly, when I'm faced with an administrative database, even if they're claiming that race was self-reported, I don't know how often I actually believe that. But so what I would say is this seems like a situation where opportunities to bring together multiple data sets really could be informative, because if we have cohort studies that are being conducted using better primary data collection tools to access information about race, or for instance, to disaggregate ethnicity into more informative categories than like Hispanic and non-Hispanic, we could bring those data sources together and use that to do something like imputation to try to impute this higher quality race or ethnicity variable for the broader EHR population. I have not seen anyone doing anything like that yet, but I do think medical researchers are becoming more sophisticated. Like, so it's baby steps, but I think we're becoming more sophisticated in our thinking about race. And I would expect stuff like that will start happening in the future. Yes.
I'm Rebecca.
Hi.
Thanks for the talk. Why not, so on the imputation and propensity score, why not just do the imputation on the atomic data, not the computed data, so not the propensity score, because that's like a computed variable. Do the imputation first and then compute or estimate your propensity score with all the data, imputed and not, and then do your weighting or matching.
So that's what we did in the original study, and that's what the multiple imputation method that I'm comparing to propensity score calibration, that's what that multiple imputation analysis was doing. It was imputing the individual variables, then calculating the propensity score, and then doing the weighting. It wasn't
still
just
the IPW after. Okay.
Yeah.
Thanks.
Yeah.
Yeah, so I've seen people with claims at least like impute race from what you have last name and then zip code and the way that I can see probabilities and categories. But anyway, that's not my question. My question is, do you have a sense of when this breaks down, like at what sample size? Because more of a statistics question, like when I try to kind of put methods together, I run into a problem when I have like not a big data problem, but like 100 people, and then you actually try to run this and then all this falls apart. Do you have a sense of like when this kind of, combination of methods would fail?
I'm not going to answer that question, but I'm going to answer a related question, because I don't have an answer for that question. But because in general, you know, in real world practice, you do encounter these multiple problems simultaneously, and it's often infeasible to do a bunch of these approaches kind of nested together. So what I'm going to say, which does not answer your question, but is related, is I think what we need to do is figure out which is the most important problem to address. So, you know, if I think that there's missingness and also confounding, but I don't have enough data to be able to do multiple imputation, think through, okay, which are the most important confounders and how complete is that data? And could I do a complete case analysis just using the confounder variables that I actually have available? Or is missing data the most important challenge? I'm going to deal with that, and you know, use the broader set of confounded variables or something like that. Like try to strategize which methods we're using rather than throwing the kitchen sink at the problem, which is often infeasible. But yeah, as far as like quantitatively when it becomes impossible to do multiple approaches, yeah, what I would probably do is just like try it and see when it breaks, see when the standard errors blow up, and then don't do that thing.
Yeah, can I, for both the mice approach and the propensity calibration, can you say something about the role of whatever the outcome variable you're interested in studying plays in those imputation approaches? Does that information enter like the survival time, for example?
So that's a really good question that I hadn't thought about carefully until you just asked it, which is we do multiple imputation. I always like hammer into people, you have to use the outcome has to be in your imputation model. Your results are going to be biased towards the null. And we do the multiple imputation in this example. We include the binary event indicator and the cumulative baseline hazard estimate. So the survival information about the outcome enters into the multiple imputation. It does not enter into the propensity score calibration. The propensity score is either computed with, you know, one set of X's or a different set of X's. And then we do the calibration, and it's completely naive to the outcome. So that's an interesting thought that the propensity score calibration is in a sense a single imputation. And it's a single imputation that's ignoring the outcome. So I'd have to think more carefully about when that might get you into trouble, because we didn't, you know, we saw it performed comparably to multiple imputation, but maybe there are cases where that breaks down.
Thank you very much. This was really, really interesting. I mean, just the intentionality with which you think about. I mean, I can't tell you the number of times students like, oh, just do it. I think it's throwing everything into an imputation. So thank you for that. Even if you're not using we have to be more thoughtful about these approaches.
Thank you.